Okay, it's going.
Okay. My name is Corey Daniels, and I'm going to talk about client-directed incentives to increase uptake of cancer screening among underserved women in small group health education settings. It's a mouthful, but I'll go over all of those things. To start off with a brief summary, breast and cervical cancer remain giant public health issues in the United States and in California. This is mainly due to women who are rarely or never screened. Rarely screened women haven't been screened in the last 5 years, and never screened women have never been screened. Evidence is needed to determine whether small client-directed incentives can increase the screening rates among these women. And so I designed a nested case control study to evaluate the issue. There were 52 cases matched to 52 controls on a confounding variable that we'll get into later. Cases are those sessions where a participant called the consumer 1-800 number to obtain services that were discussed during the session. And controls are those sessions without callers. The exposure variable of interest was the phase of a study, and that was whether or not a small client-directed incentive was offered. For 7 months, no incentive was offered, and women received a yellow code card when they went to their session. It had the 1-800 number on it, and it says, call to free cancer screening for women who qualify, and on the back there's a place for a code that was unique to the session. Once the intervention phase started, women were told that if they called and they qualified for the program, they would get a $10 gift card to Vaughn's grocery store, and on the back was a code also unique to that session. The analysis adjusted for the type of priority population, which I'll talk about in a few minutes as well. My research question was, do small $10 client-directed incentives increase the odds that women attending small group tailored health education sessions will call the Cancer Detection Program's Every Woman Counts consumer 1-800 number to determine if they are eligible for free breast and cervical cancer screening services? There are also a lot of buzzwords there that I'll get into. But first, a background. Take a step back. In 2011, the expected cases in the United States for breast cancer were over 230,000, with more than 39,000 expected deaths. There were 12,710 new cases of cervical cancer expected, with more than 4,000 deaths. In California, in 2012, coming up, we are expecting 23,000 new cases of breast cancer with 4,300 deaths, and 1,455 new cases of cervical cancer with more than 400 deaths. And it's estimated that if women were regularly screened in the United States, each year we could prevent 4,400 breast cancer deaths and 3,600 cervical cancer deaths. And what's startling about these numbers for me is that annually, 4,290 deaths are expected of cervical cancer. 3,644 of those deaths could be prevented with regular screening, which is over 80% of the deaths. Now, as I talked about earlier, reaching rarely or never screened women is an issue. They tend to be older, lack insurance, have low socioeconomic status, they're less educated, they don't have a regular health care provider, they live in culturally isolated urban areas or rural areas that are difficult to reach. They tend to be ethnic minorities or new immigrants. And one way that the state of California has come up with to reach these women is through the use of tailored health education sessions that are a small group. There's supposed to be 15 women or fewer in each session. Those education sessions are about an hour long, and they talk about breast and cervical cancer and how it affects women in their priority population and what they can do about it, how they can get screened, what they need to do to qualify for screening, etc. And then they're given this consumer 1-800 number to call to find out if they're eligible for the free screening. We wanted to find out if client-directed incentives can increase the proportion of women who are calling that 1-800 number. So we offered a small $10 reward to motivate the women to seek cancer screening services. Currently, there were no studies that reported the use of client-directed incentives to increase breast and cervical cancer screening. And Centers for Disease Control and Prevention that they put out a community guide to prevention services. They cite insufficient evidence to recommend for or against small incentives. background about the program Every Woman Counts. It's a program of the State of California's Department of Public Health, the Cancer Detection Section. It's administered by 10 regional contractors around California, so there are not technically Department of Public Health people in each of these regions, but these are contractors. Some of these regions are quite large, as you can see in Northern California and in the Inland Empire here. Each region has at least one clinical coordinator and one health educator. The clinical coordinator's job is to manage enrolling providers into the program and managing the education of those providers, whereas the health educator's goal is to encourage women to call the Consumer 1-800 number. And they do that through various outreach strategies, all tracked by the Regional Contractor Management Information System, lovingly called RCMIS, here at San Diego State University. They do one-on-one referrals with these women. They do small group planned tailored health education sessions, utilizing a network of collaborators that they have in the community. They do outreach to employers, and they table outside of Walmart sometimes. They also do attend health fairs. So the pathway to screening is long and convoluted, and there are many places here where a woman can fall off and not get screened. But this is the way it is, with state government being the way it is. Everything seems to be very convoluted. A woman attends the tailored health education session. She then receives the Consumer 1-800 number from the health educator. She then goes home and may or may not call the Consumer 1-800 number. From there, the staff who are on the phone determine whether the woman is eligible for priority population status. If she is eligible, the Consumer 1-800 number personnel mail her a letter, an eligibility letter with a letter with 3 clinicians in her area. It's then put upon her to call those 3 clinicians to see if one of them may be taking new clients and to make an appointment with one of them. After that, she has to attend the screening appointment. After that, she's enrolled in the cancer detection program's Every Woman Counts using that enrollment letter that she received way back here. So hopefully she didn't visit. And in the end, she finally receives breast and/or cervical cancer screening services. When we were approached to evaluate the use of client-directed incentives and also to evaluate the health education model in and of itself, we were trying to figure out which place in that long line of things would be best to evaluate, and we decided to start initially up here in this first part where a woman can fall off. So once she goes to the tailored health education session and she receives that phone number, does she call? What will make her call? How can we get these women to call that number? After that, after we evaluate this, then we can move on if it seems like a good idea. My case definition is a small group tailored health education session in participating regions in the state of California where code cards, as I showed you here, have been distributed, and that started after January 4th of last year. And if that session produced a caller to the Consumer 1-800 number prior to the 31st of October, which is when I had to cut my data off, as verified by the code on the back of the card. In obtaining cases and controls, they were obtained by merging elements of that RCMIS database that I talked about with the call record database from the Consumer 1-800 number that's up in San Francisco. There were 156 tailored health ed sessions that conducted during the control phase, and of those, 28 produced callers to the Consumer 1-800 number. There were 143 sessions that have been conducted to date in the intervention phase that started in August, and 24 of those have produced callers. All in all, I have 52 cases, and I matched 52 controls on a confounding variable that I'll get into. Now, due to regional differences, as you saw that big giant map, I decided that I should really be controlling per region, and I had to do that in the design since my sample size would not allow me to do it in the analysis. Now, as I said, none of those contractors are California employees. They're all contractors. They are given a set of tools that they may or may not use, and they're allowed to tailor it to their priority population women in any way they choose. So there are very big differences among these regions. I used a random number generator to hand match eligible controls to cases to eliminate selection bias. So during the control phase, which was January 1st to 2011 through July 31st, 2011, they distributed these yellow code cards, and they were highlighted as a way to evaluate the health educator. Women were asked to remember that they were yellow in color and that they have a code on the back, and they were asked to have the card with them when they call. No incentive was offered except for the possibility of free screening if they qualified. During the intervention phase, they were given the red code cards, as I discussed, and they were asked to remember that it was red in color and that they would receive a $10 gift card to Bond's grocery store if they did qualify for the program, and they had this with them when they called. My potential confounders were, as I discussed, region. Cases and controls will be matched on region. The priority population type, there are different priority populations shown here: rural, African American, Asian Pacific Islander, American Indian, and other. Each health ed session is tailored to the specific priority population that they're trying to reach. And there are very different cultural issues in each of these priority populations. So I wanted to include that in the analysis, and that's a 5-level categorical variable. Other confounding variables that I'm unable to account for in my analysis due to sample size restrictions include translation services, because they vary so much by quality and usability. The size of the session. So ideally, as I said, the state asks the contractors to make sure there are no more than 15 women in each session. However, when I look at RCMS, I see that a few regions tend to have about 30 or 40 participants in their sessions. On the other side, a lot of these women are coming with women who the session is aimed at. For example, an 80-year-old woman will come with her 30-year-old granddaughter, and obviously the session is not tailored to the 30-year-old granddaughter. She's there because she needs to be there with her grandmother. So very small sessions have fewer participants that can call, that decrease the chance of a successful session. On the flip side, very large sessions are thought to not be as effective at reaching women because they aren't as personal. For minimizing bias, I had for selection bias, a clear definition of the population, the cases, and the controls. The controls were from the same base population as the cases, and I used a random number generator to select the controls. Misclassification bias, we designed that out by using the red and yellow cards so that they would be very easy for the 1-800 number personnel to know which phase they were coming from, either the control or the intervention. And there are different scripts used for whether or not the woman has a yellow card or if she has a red card. Participation bias. All the participants from all the sessions selected themselves to go to the session, so hopefully that's not a bias, it's more of a systematic thing. Information bias. No diagnosis bias, as we have the same information on the cases and the controls since it was collected prospectively, and without information on whether they were to become a case or a control. The one thing that is a problem is I have a very underspecified model due to sample size restrictions. My sample size and power calculations, I took a look at an 80% power with an alpha of 0.05 with my 8 levels, my 8 strata, and an odds ratio of 2. And it said that I would need 193 cases. When I took a look at a power calculation to see what my power was as is, I have about 30% power, which is not very good. For a detectable alternative, first I put in my current information with my 30% power, and I have my detectable alternative is either a 0.45 or a 2.0. And then I just, for fun, I put in an 80% power with my 52 cases and my 8 strata, and my detectable alternative was 3.79. All of my calculations were performed with power and sample size version 3.0. And those are my references.
Thank you.
Are there any questions about the very confusing terms and
Questions, you guys? It's not fair if you don't ask her questions. Can you go back to one of your slides that shows the number of people
This one?
there? Yeah. So you have 28 were the control group, is that what